All right, good evening, everybody. I believe in starting on time. So welcome, my sorors, welcome guests. Today we are here to discuss a very important topic specifically in regards to the Black community, Black women, and really just shedding light on something that is so important. Um, More recently in the last few years, and you'll hear from speakers, just talking about Black maternal mortality rates have significantly increased, negatively impacting the Black and Brown community, specifically Black women. And so we wanted to host a forum that gave some information, insight, as well as resources for women to advocate, educate, and be more aware of these statistics as well as this disease. So my name is Jakari Henderson, and I serve as the Gamma Kappa Omega Chapter President. I welcome you all. I'm really excited for this evening. I think this topic is something that needs to be talked about more. Black women need to be at the table more when these conversations are happening, just so that we can advocate for ourselves more, we can educate ourselves, and really make an impact to protect ourselves as well as our families. So good evening, welcome. And so just to shed a little bit of light about why this is important to Alpha Kappa Alpha. So Alpha Kappa Alpha will continue to raise community awareness of critical health issues impacting African American women. Some of our primary focuses will be breast cancer awareness and prevention, heart health, nutrition and wellness, and care for the caregivers. Again, this is something that impacts specifically a number of Black women. So we wanted to make sure that we had a discussion about this particular topic. So I'm going to now turn it over to my soror, Crystal Robertson McClendon, who will talk about defining what Black maternal health is.
Thank you, Madam. Maternal health is the health of women during pregnancy, childbirth, and the postpartum period. It encompasses the healthcare dimensions of family planning, preconception, prenatal, and postnatal care in order to ensure a positive and fulfilling experience in most cases, and reducing maternal morbidity and mortality in other cases. Black maternal health is focused more on the women of color, stating the neglect receiving from providers or caregivers who fail to take their issues or concerns seriously when mentioning they're in pain, when there's something doesn't feel right, or just being misdiagnosed. Tonight, I have the great honor and privilege of introducing our speaker for this evening, Dr. Eboni January. Dr. Eboni January is a board-certified OBGYN, author, health and educator, coach for over the last 10 years of experience. She earned her Bachelor of Science in Biology with a minor in Chemistry and Anthropology from the University of Missouri in Columbia. She then went on to receive her medical degree from Wright State University, School of Medicine. Dr. January is a multi-dynamic business professional with a passion for preventative medicine, mentorship, and fitness. To date, Dr. January has spoken at over 30 schools, 20 corporations, coached over 240 students, and 1,200 corporate staff members and business owners via her text group coaching. In 2015, alongside Olympic gold medalist Jackie Jonah Kersey, Dr. January helped promote a large childhood obesity campaign impacting over 20,000 youth. Her health and wellness podcast, The Wellness Wheel, at CBS Radio introduced all communities to a holistic approach to health and wellness via celebrity guests, fitness trainers, actors, and many more. In 2016, she developed a texting coach program in an effort to decrease the growing number of patients facing complications involving obesity and cancer. The program, FitText, had been featured on a number of news outlets such as Fox 2, Gazelle Magazine, I Am East St. Louis Magazine, and the St. Louis Argus. As in 2016 and 2017, she was granted the Lifetime Achievement Award from President Barack Obama, Most Intriguing Women in St. Louis, the 30 Leaders in Their 30s Leadership Award, and the Lifetime Legacy Achievement Award in medicine. Along with her love for medicine and her health, her passion for coaching the youth had her heart as well. As an East St. Louis native, she's worked with the youth and young adults for over 10 years, granting over $50,000 in personal scholarship funds. In 2018, she authored the book Educational Athlete: Why Every Successful Student Needs a Coach. This book is the blueprint for parents who want their children to be ready for everything life has to throw at them. From elementary school to graduate school, Dr. EJ hosts a mentorship program that works to teach both parents and students different strategies step by step that could help children to obtain their educational goals. One Illinois high school, known for their academic endeavors, went on to build an entire curriculum around her book. In 2020, while working during the height of the pandemic, she developed an online platform that speaks to growing needs of education and health teaching during the digital age. Her mission is to empower the community to achieve extraordinary endeavors as it relates to a whole body care while redefining the perimeters of success. Dr. January also developed a boss-ish brand that's tailored to fit every boss on the go. Products include a meal replacement kit, resistant bands travel kit, or a bundle that you can receive 1 free month of text fitting. Dr. January has current features with Fox 2 as a speaker on Saturday mornings at 7:40, Greenlight Medical Director, Real STL News Correspondent, and Educational Athlete Power to Play. Please help me give a warm Zoom welcome to my best friend of over 20 years, the epitome of Black girl magic, Dr. January.
Thank you. What an amazing introduction. Thank you so much. Now, I must admit, I'm not very tech savvy, so I am trying to get on so that you all can see me. Let's see here. Are you all able to see me yet?
Not just yet, just your picture.
Okay. Well, I am going to share my screen with you all. Let's see. I believe you have to allow me to share my screen.
You should be able to share now as a co-host.
Okay. Still unable to allow me to share it. Let's see, I'm going to try again here. I may have to change the setting. For some reason, it's not allowing me to share my screen.
Okay, let me take a look and see what is going on as to why it's giving you. I'm going to remove co-host permission and I'm going to give it back to you as well. Okay, so try it now, Dr. January.
Not yet. That's odd.
Okay, do it again.
Okay, okay. Just a second.
We're gonna give our speaker a few moments to hop back on. I think she got disconnected. And then we're gonna continue on with the session.
Okay, I'm back. Can you hear me?
Yep, we can hear you and we can see you.
Perfect. I'm like, what is happening?
Okay, we could just see you for a second and then it just went back off.
Because I'm getting ready to upload the presentation.
Okay.
There we go. Oh, Jesus. All right. Can you all hear me?
Yep.
Can you hear me?
Yep, we can hear you.
Perfect. Finally. Sheesh. Can you see my screen now?
Yep, we can see it.
Finally. Whew, we got action. All right. So we're here to talk about morbidity and mortality amongst African-American women. So the first thing, many people, they know the word mortality, pretty familiar with it, but not necessarily the word morbidity. So the first thing is, obviously, we know that mortality refers to death. And unfortunately, each year, 700 women die during pregnancy. 3 out of 5 really could have been prevented. And so that's, for me, the most unfortunate thing. And it's really hard for me to read and really hard for me to say, being an OBGYN for the past 12 years. 50,000 women, however, experience severe pregnancy complications that cause severe consequences that tends to alter their life, as many years go on. Black women, unfortunately, are 3 times more likely to die from pregnancy-related causes than white women. Now, when we talk about morbidity, these are the physical and psychological consequences that result, or conditions that result from or aggravated by pregnancy. For example, if someone has a history of high blood pressure, then they can go on to develop preeclampsia or severe preeclampsia as the pregnancy progresses. So this is a morbidity that is aggravated by pregnancy, and they go on to have adverse effects on a woman's health. Unexpected outcomes as well that result in short or long-term consequences are referred to as morbidity. Maternal age, pre-pregnancy, obesity, pre-existing conditions, cesarean deliveries, racism, chronic stress, and trauma are also causes or morbidity amongst African-American women. Access to hospitals, discrimination, and quality care as well. So I wanted to take a step back and talk a little bit about the history of Black women as it pertains to morbidity and mortality, and also our relationship with reproduction as well. So historically, in the 1600s, Black women were forced really to do farm work. We were forced to bear children that basically would just go on to work on the plantation. So basically we were responsible for birthing workers. And unfortunately, there was a law passed in 1662 that made children of slaves the property of slave owners. So they had the right essentially to control our children, our slaves' our capacity to bear children as well, So we refer to this as forced mating for the purpose of increasing female fertility and also raising enslaved people for the primary purpose of sale. In the 1800s, as if that wasn't bad enough, Black women were also subjected to medical experiments. Doctors relied heavily on experience and observation in the study of gynecological medicine. In the 1900s, Black women in reverse were actually demonized as their sex and reproduction were symbolic of what was wrong with society. So basically we became discriminated against because we reproduce essentially. But during slavery times, they wanted us to reproduce. So it was more of a reverse. It was like we couldn't do anything right. So they wanted us to reproduce for just the pure goal of to make more slaves essentially. But now in the 1900s, here we are being demonized for those same things. So we talk about the role of OBGYNs, midwives, and doulas. And I know that we have some doulas that may potentially be joining us and some midwives as well. And I'm happy that they're here. But essentially, everyone plays a part in the birth. Everyone plays a part in women's health. But as OBGYNs, essentially, we are the people that maintain the overall health in conjunction with midwives, doulas, and nurse practitioners. We perform deliveries during childbirth, C-sections, vaginal deliveries, whether it's forceps assisted or vacuum assisted as well. And then we go on to conduct the postpartum care. The role of midwives, and I don't want to speak too much on the subject because, I may get some of this wrong, something that I do, but I work very closely with midwives. But they essentially do, from an obstetric standpoint, they do very similar work to what we do. So they check the baby's health, the growth position. They advise women as well. So they act as an extension of physicians. And in some areas, they actually do very similar things to what we do. So they'll do normal births. In certain hospitals, they'll actually assist in C-sections as well, which we find to be extremely helpful. They advise on or help hospital bookings, routine tests, checks, and such. They give support and they also advise, and they help expectant mothers prepare for labor and birth. During labor, they give information, encouragement, emotional support, monitor the progress, and also suggest strategies to help. But in certain hospital settings, midwives actually do the deliveries. In most, if they're in a hospital setting, 9 times out of 10, they'll also do the deliveries as well, especially if they're low risk. They'll monitor the baby's heart rate, they'll offer pain relief, also arrange for a doctor to administer it as well, anesthesia. They get extra medical help if necessary. After the baby is born, they help with breastfeeding and also settling with the baby. So many women don't necessarily, especially first-time moms, they're not really familiar with breastfeeding and how latching on. Some women get frustrated. So sometimes midwives will step in to say, okay, this gives them a little bit more instruction as well. Oftentimes they'll administer pain relief. They'll carry out some routine health tests and newborn screening as well in certain settings. Doulas, who we actually as an OBGYN I love, and we just recently received a presentation from a group of doulas here in St. Louis who I thought were phenomenal, but they go a little bit further with that extra attention, physical comfort through techniques such as touch, massage, assistance with breathing, emotional reassurance, comfort and encouragement, information about what's going to happen during labor, the postpartum period, including explanation of procedures. They help with facilitating communication, which I find to be very helpful because sometimes when women are in pain, sometimes they're very emotional during labor and they may not necessarily be able to take in the information that is given to them, or sometimes they're unable to articulate what their needs are. So that's where the doula steps in and actually essentially acts as a liaison and a translator as well. So we really appreciate that because sometimes they have had a relationship with the patient that we may not necessarily have. And so they step in, they're able to talk to them differently and really comfort them and offer more guidance and support and also assist with breastfeeding as well. The other things that doulas do, they also, I had more information about doulas, but anyway, it's not on the slide, but one of the things that doulas do is that they don't just care for the patients themselves, they also care for the family members, which I find to be extremely helpful because sometimes family members may not necessarily come to the doctor's appointments and they may not necessarily know what is going on. So the doula goes that extra mile to actually not just care for the patient, but also to care for the patient's family members as well. So I actually like that, because sometimes men, they just need a little bit more explanation. And with them not coming to doctor's appointments sometimes for whether their work or, things like that, just a scheduling issue, then doulas can actually act as an extension of us as well. So postpartum, how we act as doctors is that we typically see patients within 3 weeks. Sometimes it's a week period, sometimes it's 6 weeks, but in general, we want to see patients back within 3 weeks. We want patients to also, if they have a complicated delivery, for example, a C-section, a back tear, severe preeclampsia, then we like to see them a little bit sooner. So that's something that we do as OBGYNs. And we also, what we encourage women to do is to have a postpartum preference plan. So these are things like if they want to be placed on birth control, if they're going to plan to breastfeed, those kind of things. Those are the other things that we do as OBGYNs in the postpartum care. We encourage women to discuss, their recovery, ask us questions about their recovery as well. Things that they may not necessarily know. Everyone's more so focused on the pregnancy itself, the baby itself, but they're not necessarily focused on the recovery side of things. Some in certain settings, and I wanted to reiterate this, we like to see patients sooner than 3 weeks. We like to see patients sooner than the 6 week. If patients have high blood pressure, preeclampsia, heart issues, then we like to see them within a week's period of time. We also encourage patients, if they have some type of comorbidity, or if they have an issue with their blood pressure, to also establish a foundation with their primary care physician within 2 weeks of delivery, and also to seek cardiac evaluation. Many times they don't necessarily have the time to go to primary care physicians. So we encourage women to come back to us so that we can get that care coordinated and maybe refer them to cardiology as well. So current state, where are we? So in 2020, we actually increased our morbidity, maternal mortality rate almost 37% from 2018. So in 2020, there were 861 maternal deaths. As far as Black women were concerned, 55% of those were Black women, 19% were white women, and 18% were Hispanic women. And unfortunately, women nowadays, we're more focused on our careers. So now more and more women are having babies older than the age of 40. And unfortunately, women 40 plus are 7.8 times more likely to die in pregnancy than their counterparts who are younger, around the age of 25. And as I stated before, and I alluded to this, I was going to go back to this, but I alluded to this earlier, which is that 2/3 of reported maternal deaths are actually preventable. So what are women dying from? The number one cause is cardiovascular disease, unfortunately, and especially as it pertains to African-American women. So 15.5% die of cardiovascular issues, 12.7%, and unfortunately die of infection. 11.5% cardiomyopathy. Hemorrhage is 10.7% of the cause, and thrombopulmonary, and sometimes this is DVT or deep vein thrombosis, which is in the legs, that's 9.6% of the times, and cerebral vascular accidents as well, 8.2%. Many times when this happens, these are women who have had issues with their blood pressure, preeclampsia, severe preeclampsia as well. So the CDC reports between 2014 and 2017, the number one causes of death were hypertensive disorders, amniotic fluid embolism, anesthesia-related issues. There were also some non-cardiovascular medical issues in 12.5% of the case. The cause of death, and unfortunately, in 6.7% of the cases were unknown, which is, in my opinion, way too high for us not to know what's going on. So what can we do in the future? Many places, especially in the state of Missouri, I sit on councils where we've actually mobilized a lot of forces, task forces, so that we can decrease morbidity and mortality amongst African-American women. One of the things that we focus on is minimizing health disparities through innovations, cultural competency, which is something that across the board, not just as it pertains to obstetrics, but just across the board, many people lack cultural competency, many healthcare providers lack cultural competency. So there are initiatives that we've tried to put into place so that we can educate clinicians on cultural competency and really just try to be more creative as it pertains to educating African-American patients, not just women, but also their counterparts as well. We've also tried to invest in a more diverse maternal health workforce. So, one of the things that I like that I'm seeing is more doulas, more African-American doulas who are joining that, and they're seeing that there's a need there. So that's one of the things that we've tried to support. So one of the ways is that we bring doulas on board from some of our high-risk committees to, kind of educate us, give us presentations, let us know that they're there, so that we can, play as a team, really, because sometimes, certain things are frowned upon. Many doctors who have been doing this for a very long time, they're not necessarily ready for change or to see someone different in the delivery room. But, a lot of us really appreciate the doulas and the midwives that are in the delivery room. So, we're really trying to expand our reach there and expand that workforce. So more midwives, more physician assistants, nurse practitioners, family physicians, doulas, and such. In addition to that, something I'm very happy about is that Missouri has expanded Medicaid. So usually women would only have Medicaid up to 6 weeks postpartum, but now they've extended it to a year. Many studies show that really the postpartum period can be up to a year in time, because many people think that, historically it was 6 weeks and, that their body just really got back to normal 6 weeks. But as we see more and more women, it's taking a little bit longer to get back to normal. So they've extended Medicaid coverage to 1 year postpartum. So that's something that we've been very excited about, something that we've been pushing in the state of Missouri as well. In addition to that, healthcare, quality healthcare, respectful healthcare, and also respectful childcare as well. That's something that a lot of patients and a lot of people struggle with is childcare. So they don't necessarily make it to their visits because they have to take care of their children. They're busy, doing so many things. So they don't necessarily have that, in the state of Missouri. And there may be people on the call that are not from Missouri, but in the state of Missouri, we have places like the St. Louis Crisis Nursery, which, they act as really an extension of women's care, where, if you're struggling, if you're really going through something emotional, you can drop off your kid for 24 hours. So that's something that I think that, needs to be implemented in more cities and more states. The other thing that we can do and that we're trying to do is integrate health services, biomedical, behavioral, social sciences. So really understanding why socioeconomic gaps exist, understanding why health disparities exist as well. Those are some of the things that we are trying to look at so that we can best care for patients. The other thing is advocating. One, I really encourage women to advocate for yourselves, advocate for your family members, get involved in research, have a say in research. So, even though we have a history of research we didn't have we were guinea pigs essentially. Even though that was present, we still need research in order to progress, in order to really understand our bodies, and really understanding why we are at higher risk for poor outcomes than our counterparts. So, definitely having a voice in research is something that we do have to get involved in. We need to educate ourselves as it pertains to research as well. The other thing that many people don't necessarily know about is the Black Maternal Health Caucus. And they are actually very involved on social media, Instagram, Facebook. So I encourage a lot of women to get involved, reach out to them, follow their page, educate. They have a lot of educational things on their sites as well. So definitely get involved, know what your resources are. Make sure that you know what studies are out there. Make sure that you're educated about studies, because many of these studies are directed towards us because we are people who don't necessarily have the best outcomes, not just in pregnancy, but just across the board. The other thing is spreading the word, doing more Zooms like this, doing more outreach efforts, going to more health fairs. These are ways that we actually are able to advocate for ourselves and other women. We definitely have to spread the word. All too often, we spread negative things and don't necessarily spread things that benefit us. So I definitely encourage people to spread the word. So what can we do essentially besides spreading the word, besides getting involved? Well, you want to make sure that you're having conversations with your healthcare provider. Me, I'm an open book. People reach out to me all the time on social media, on Facebook. you got to definitely have these conversations with your healthcare provider. Know that they're people too. If you don't feel comfortable having that conversation with them, then maybe, maybe time to switch doctors, or even consider a nurse practitioner or a midwife, someone that, you can relate to. It's not necessarily, some people may not relate to midwives or nurse practitioners or, even a doula, but it could definitely be your doctor. But if you don't have a good conversation or a good relationship with these people, then you may need to go seek other people. Other things, know what is not normal. Severe headaches in pregnancy, not normal. A lot of people will have swelling in the feet, but not necessarily in the face, around the eyes, in the hands. Many times this is abnormal. Trouble breathing, heavy vaginal bleeding, overwhelming tiredness. This is, when we talk about these symptoms, we're referring to that cardiomyopathy, and we'll talk about that a little bit later. But cardiomyopathy is something where women, especially African-American women, are at higher risk of developing. These are the things that we're seeing that are causing high morbidity and mortality. So many people will experience severe tiredness out of nowhere, dizziness and fainting as well, changes in their vision. These are also signs of preeclampsia as well: fevers, chills, high fever, chest pain, severe nausea, severe pain in the belly, which could also be a sign of placental abruption. So essentially the placenta separating off improperly. If baby's movement has slowed down. I always talk about kick counts when we talk about kick counts, as you progress in pregnancy, sometimes it's not a flat out kick, sometimes it'll be more of a roll. So these are 10 movements in 2 hours. The other thing that we can do is document. I tell people, if you're going to have your phone out, make sure that you're documenting. If when you go home, you think of any questions, make sure that you put those in your phone so that when you come back, we can actually go over these questions. And you want to really keep a history and documentation up to a year postpartum, because you really want to know how your body has changed in that period of time. Other things that we can do is bring a support person, really, not just to the delivery room, but also to the office for your visits. I tell people, if I'm going to operate on you, especially women who are going to have C-sections, bring someone in. They want to know, they want to meet the person who's going to care for you, the person who's going to cut on you. So make sure that you have a support person. If it's not a family member, a doula. Educate yourself by going to birthing classes as well. Mental health is so important as well during pregnancy, especially women who have had multiple children. So you're just managing a lot, you're working, you're trying to cook, clean, do everything. So mental health is very, very, very important. So just speak up. Ask for resources. Sometimes, people don't necessarily know that resources exist. There are resources that are available. So we talked about this a little bit more or before, but I want to talk about this a little bit more, which is the causes of death in Black women. Postpartum cardiomyopathy. This essentially is where cardiomyopathy can actually come in 2 forms, where the lining of the heart can actually thin and it doesn't pump properly. The other cardiomyopathy is where the muscle of the heart actually gets a little bit thicker. And so for that reason, many people will have difficulty getting blood flow to the brain, to the rest of the body. And unfortunately, it can get to a point where it stops pumping. The other leading cause, blood pressure issues, preeclampsia and eclampsia. Now, many people are very familiar with preeclampsia. However, the one thing about preeclampsia is that it can really develop up to 12 weeks postpartum. Not a lot of women know that. And every time I actually educate people on that, they're very shocked that they don't know that actually more women actually come back with preeclampsia than they're diagnosed during pregnancy. So, and in addition to that, many women who struggle with preeclampsia actually may potentially seize in the postpartum period as opposed to during pregnancy. In addition to that, preeclampsia, you can not just seize, but you can also stroke. So a lot of people, they think that they're just done. I've taken the blood pressure medicine, I'll just come back for my 6-week postpartum visit. But in actuality, they really need to be followed up with that week. We need to know the signs and symptoms of preeclampsia. So once again, headache, spots in the vision, you just overall not feeling well and struggle with blood pressure issue during the pregnancy, you definitely want to come in. So many people take it for granted. They get home, they're busy with baby, they're busy with other things. And so they forget to get their blood pressure checked. And so this is one of the #1 causes of maternal death in Black women. So we want to make sure that we are taking blood pressure issues seriously. Embolism, so blood clots, hemorrhages as well, and also complications during C-sections. The one thing that I like to talk about here is that a ton of Black women will get C-sections, unfortunately, because they just don't know any better and they don't advocate for themselves. In addition to that, it has a lot to do with anatomy. Many Black women, even though we have big hips, we have narrow pelvises. So this is where we have what we call cephalopelvic disproportion, where the baby's head is just a little bit too big for the pelvis. So then you go on to have, C-section, then C-sections in the future. In addition to that, gestational diabetes is one of the things that can also cause us to have big babies or babies that don't necessarily fit. So we want to make sure that we're maintaining a healthy diet as well, low on the carbohydrates, higher on the protein and the vegetables. Things to make sure that we take into consideration in the future is just education. Education is key. Go out there, get the information, reach out to doctors, go to health fairs, do the work. Definitely do the work. I tell people, don't necessarily just leave it up to the healthcare provider. Make sure that you do your part. It's your body as well. And let's have a team approach to healthcare. So make sure that you're educating yourselves on reproduction, fertility, birth control, and the consequences as well. Also, one of the things that we can improve upon is just access to care and also pre-existing conditions. Many people don't necessarily know that getting healthy prior to pregnancy is just as healthy as maintaining a healthy weight or a healthy diet during pregnancy. You want to make sure that you are preparing for pregnancy. If you are, getting married, a newlywed, and you guys are wanting to have children or what have you, you want to make sure that you go and get a physical, get your blood pressure checked, get, diabetes testing, get your cholesterol checked. All of these things. If you have a family history of heart disease, you want to maybe even get an EKG or echocardiogram, which is ultrasound of the heart. So you want to make sure that you are preparing. If you have existing conditions before pregnancy, make sure that they are controlled. You want to make sure that if, for example, many people may have psychiatric issues, one of the things that we try and do is we just minimize them to one medication if possible. Sometimes they'll be on multiple, but for pre-pregnancy, we want to make sure that they're just on one. So make sure that you are caring for yourself before pregnancy. If you have any issues before pregnancy, high blood pressure, diabetes, we want to make sure that it's controlled prior to pregnancy. Cleanliness as well. We have in African-American women, there's a high infection rate. So we want to make sure that, cleanliness is definitely key. So that's one of the things even before and after delivery. So after delivery, as I stated before, many women will get C-sections, but if they don't care for their incision well, then they come back with infections that can get pretty severe, especially diabetics. Diabetics tend to heal very poorly. So we want to make sure that diabetes is controlled if you're going to have a C-section. And we also we want to make sure that you are cleaning the incision very well. So we talked about pre-pregnancy care as well, making sure that, you're doing the part, you do your research, who you want to take care of you. Tour the hospital, tour the clinic as well. Go to some of the labor rooms, get familiar with it as well. And postpartum monitoring, which I talked about before, we want to make sure that you're coming back for your visits, coming back for your blood pressure check. If you feel weird, dizziness, lightheadedness, even if you weren't diagnosed with blood pressure issues during pregnancy, we want to make sure that, you're paying attention to your body in the postpartum period. So what else can we do? Well, we want to expand and maintain, as I stated before. Some states have expanded Medicaid, some places have not. But what most people don't know is that it actually exists. Many women don't necessarily know what their benefits include. So we want to make sure that we're asking these questions. Other things that we can do as providers is that we need to make sure that we have a patient-centered care approach to the needs of Black women. So people who are not necessarily African-American and are, Caucasian, Hispanic, or what have you, clinicians that are caring for women, we need to make sure that we understand the needs of African-American women, that we're not just treating, African-American women as everyone else. There are other social determinants of health that play a role in healthcare. And also even considering paid family leave, the expansion. So that's something that we've toyed around with quite a bit as well. Other considerations, like I stated, was expanding the quality patient-centered care, trusting your providers, and also protections against pregnant women, and investing in healthcare safety and quality improvement initiatives. And that is all I have for you. That is how you contact me, Dr. EJ at drej.com, my Instagram and Facebook as well.
Thank you so much, Dr. January. That was phenomenal. I'm sure a lot of people learned a lot of just helpful and insightful information that they didn't know prior to. We're now going to go back into our, to prepare for our panelist discussion. I am very happy. So this is one of the first times that I have a panelist of all of members of Alpha Kappa Alpha Sorority Incorporated. So you all get to see the phenomenal work that they are doing. So first, one of our panelists, we have my soror, Dr. Felicia Kimbrough. She is a board certified nurse practitioner and currently practices at Terrier Care in Carbondale, Illinois at the Carbondale Community High School. She is an active member of the community. She has spoken at various schools, companies, and even has a TED Talk. She is a strong advocate for education and awareness.
Next, we have our soror, Crystal Robinson Clendon. Nurse Crystal has experience as a postpartum nurse for Barnes Jewish Hospital, geriatrics nurse for Lansdale Nursing Home, River Crossing Rehab and Nursing, Whitehall Rehab and Nursing, and is currently the lead nurse in the Women's Health Department at the People's Health Center in St. Louis, where she treats and educates patients on sexually transmitted diseases and infections in health. Currently, she is working on her master's in family health. Family nurse practitioner at Chamberlain University, and she will be graduating this fall of 2023.
We also have my soror, Deria O'Reilly, who has her BSN. She also has her MSN and has over 6 years of experience. She has worked in med-surg, OB, PCU/step down, in the ER, and as a house supervisor. She has also served as a travel nurse for 3 years, and currently she works as a nurse practitioner.
We have my soror, Monica Spears. Monica Spears, she's a BSN. She graduated with her master's in 2019. Currently, she's working as a family nurse practitioner for Molina Healthcare. Since the pandemic, she has been a telehealth provider serving the Illinois and Washington state community.
And we also have Dr. January, who is also a member of Alpha Kappa Alpha, who has extraordinary experience in working in the health field. So now we are going to allow individuals to ask questions from the group. If you have a specific question, please raise your virtual or your real hand if you're on camera, and then we will call on you for. Okay, so I see you, soror Faith, you have your hand raised. I'll go ahead and give you the first question, and then Chloe, you'll be next.
Okay, good evening, everyone. And I don't have a question, but I did want to introduce or just mention that we do have a doula on the call as part of the participants, and that is Kyla Connor. She also is a birth worker, and I'm not that educated about a doula and birth worker. I don't know if the terms are interchangeable, so perhaps she can share some light on that if there's time.
Thank you, soror Faith. And we'll definitely let Kyla chime in as well. Chloe, go ahead and ask your question, soror.
Okay, thank you. Well, thank you all for giving us your time. I really appreciate that. I've learned so much. I'm currently 6 months pregnant, and it has been a journey for me trying to find a midwife and a doula. And thank God I ended up finding one, because I'm in the Carbondale area and there's not very many options for me when it comes to that, because I wanted to do a home birth. If I wanted to birth in a hospital, it would be a different story. But since I wanted to do home birth, it was a little difficult for me. So my question would be, and even for the doula that's also on here too, or anybody who wants to answer, but what advice would you give to someone who basically doesn't have the opportunity to have a home birth, but they want to still have the experience of having someone like a midwife or a doula to advocate for them, because being in a hospital is scary, and not being educated going into stuff is scary. And that's one thing that I was afraid of, was not being able to have my own birth experience, or having someone tell me that I have to do something specific with my body when I don't necessarily have to do that. So what would you recommend? What steps, or who would you recommend someone to go to if they had to end up giving birth in a hospital with typical like doctors?
And I'm going to start with the source I see on screen. So Monique, I'll let you start first. Deary, Crystal, Sora, Felicia. And then I'm looking for Dr. January, because I know she's on here as well. But that's the order that we'll go in. So go ahead, Sora, Monique.
Hello, everyone. But Chloe, yeah, I understand what you're saying. So you want to have a home birth, but you're not able to. So the best advice that I can give is trying to establish care with a doula, so you can have someone that's there that's advocating for you. Doulas, usually you'll talk to them and then you'll tell them your birth plan, and their job is to advocate for you so you can stick with your birth plan, and you're not necessarily being forced into things that you don't want to do. Your wishes are already written and stated, and it's their job to make sure those things are followed through, so you're feeling more safe and secure, and you're able to just worry about you laboring instead of worrying about, is this person doing this right? Or if they're, are they listening to me? So just having someone there for you to help advocate your wishes will probably be the best thing for you.
Sora, Deary, if you want to chime in.
I agree with everything that Mo said. I think that's what would make you most comfortable, is just, letting it be known what you want. Now, at the end of the day, if it becomes high risk and, you need to adjust your plans, then you may have to, but yeah, just letting them know what your wishes are up front. And also not just with a doula, establish, if you have to establish with a physician, as long as you have a good relationship with that physician, you can let them know, what your wishes are, the same way you can let a doula know. It's just about you guys' relationship and making sure that you guys do what's safest for you and baby as well.
Thank you, Deary. Crystal?
Absolutely. I think that what the two sorors before me stated is absolutely correct. Just making your thoughts and your wishes known up front with your doula. And I agree. I agree with everything they said.
Sora, Felicia?
I agree. They haven't said anything that was wrong. Just, I guess, to piggyback on what Darielle said, I think a big part of having a birth plan for anyone is just to remember that it is a plan, and sometimes it just doesn't go that way. And just making sure that you do have those relationships with all facets of the team. So that would include also OBGYN, and to make sure that you are discussing what your wants and desires are, with the understanding that if it is in the best interest of your life or your unborn child's life, that those plans and hopes may have to be altered a little bit, but to feel confident that everybody on the team has an end goal for a healthy mom and baby.
Thank you, Sora, Felicia. Dr. January?
Yes, I completely agree. You definitely want to make sure that when you establish care with the physician, just in case, and also ask about your options. Go in with the birth plan. If they don't necessarily do home births or a water birth, you can see if they have a room. Some places will have a room with a tub where they can somewhat, give you the experience that you want. The reason why we talk about making sure that you establish care with the physician is because you have obviously nurse midwives and doulas, they serve their purpose, but we're there to make sure that we handle any complications, anything that's high risk. All too often, we've had home births that go pretty bad. So it's not that we don't care to do home births. That is definitely not the case. Is that we want to make sure that you're educated about all of the things that could potentially happen with a home birth, and so that you make the best decision possible, but also have a team approach to your healthcare. If you want a home birth, establish with the physician, ask them about options, because sometimes you don't necessarily know that there are places that will allow you to do whether a water birth or home birth with the doctor on call, with the midwife on call. So make sure that you explore your options, ask questions, ask around, do the research, because sometimes there are options available to you, but make sure that you've had a conversation and you got multiple people on board, because we all back each other up.
Thank you, Dr. January. Kyla, I saw you had your hand raised. I know you're a doula, so I'll let you go ahead and unmute yourself as well to chime in.
Hey everyone. So I did want to go over Chloe's question before I give more insight about what I do. For Chloe, just basically what everybody said, but from the doula perspective, do go over your birth plans. And I know that it might not be, your best interest, but some people do still do things virtually because of COVID, obviously, but in some places, like as far as Carbondale, don't have actual birth centers. So that can be an option for you. Definitely go over your birth plans with, your doula or your physician or anyone who you, seeking care from. And if you have any more questions, like if you want to ask personally, you could definitely talk to me outside the chat, outside the Zoom.
Thank you so much. I appreciate everybody. That was very informative.
Okay, so basically, yes, I'm a birth doula. Been a birth doula for 2 years and been a postpartum doula for 1. Basically, what I do is just be the advocate for the women during the whole pregnancy, during prenatal, postpartum, especially during labor as well. I provide physical, emotional, all the support. I'm basically like the partner without being the partner. As a community birth worker, as Ms. Faith mentioned, I do a lot of things within the community as far as doing legislative work. I actually currently work with the CDC about passing laws to have doulas implemented in hospitals throughout Massachusetts and Chicago. Those are the 2 states that I work for. We're implementing doulas to be a part of the team and as well as provide Medicaid in underserved areas. So that's a little bit of what I do. I'm trying to think if I missed anything. Yeah, as far as being a doula, I of course don't provide medical advice, but I do actually provide information that I know as far as research and listen to clients or parents or anybody who wants a doula come up with birth plans and present it and build that relationship with either if they have a midwife or an OBGYN.
Thank you so much, Kyla, for sharing as well. Other questions from the group? Well, I'm gonna just go ahead and ask mine now because I have a few. So you talked about, obviously, a lot of Black women not experiencing motherhood until later in our, late 30s, early 40s, because we are seeking, our career goals and aspirations. So I don't have any kids right now. And, obviously that's something that is heavy on my mind. I'm not going to lie and say that, a lot of these statistics and the information that has come out about, Black maternal health rates have not been a little scary. I actually had a soror that was texting me as well. She was like, I was ready to have another baby. I'm scared now. And I'm like, I don't even have any and I'm scared, And so I guess what recommendations would you all offer? Like, I know you talked about like advocating, for yourselves and educating yourselves. I know specifically like in the Carbondale area, we don't have a lot of, OBGYNs that look like us. You may have, 1 or 2 specifically, in a community that, you know, it's really hard to feel like you have all of the resources to kind of, you know, navigate that process with those who look like you, who also, you know, listen to you when you're, you know, advocating for yourself. So what would you all recommend for those who are in that kind of career, you know, chasing position, you know, who do want to become mothers in the future? You know, and not being nervous about, you know, this conversation, because I mean, like I said, realistically, like I'm nervous, you know, I'm in my early 30s, but you know, I don't have a husband. So I know I probably won't be able to have a baby for about another 2-3 years unless I meet someone. And that puts me at mid 30, you know, and so the chances of having, you know, several children at that point are kind of decreased because I'm not having any babies 40 plus. I mean, that's not something that I want to pursue. And then I'll kind of go backwards. So I'll go Dr. January, so Felicia, Crystal, Derry, and then Monique.
Okay. So one, that is a very great question. And it's funny because when I was presenting, I was like, oh my God, I know that I'm scaring so many people, right? But this is why most people know me because of my outreach efforts. I really push preventative medicine, preventative health. And in fact, I think Soror Crystal has the link to, I have a guide coming out, which is Dr. EJ's Guide to Controlling Your Health, the women's edition, right? And I originally came out with a version, probably 4 or 5 years ago, which was about general health, because what I found was that many people, they would be on medications or have, you know, all of these chronic issues, but they wouldn't know what medications they were on. They hadn't gone in for any screenings in a long time. So the guide was an area that not just educated them, but also they were able to put their lab results, their medications, you know, they got brief snippets of just what they needed to know in order to maintain a healthy lifestyle. So in this guide, it actually touches on almost everything that you said. One, fertility, right? So as we age, we know that we are born with a set number of eggs, right? And as we age, that amount goes down. And after age 35, it goes down significantly. So what career women need to make sure that they're doing is, one, consider freezing your eggs. Definitely. Consider freezing your eggs. There are more resources out there for that now. A lot of jobs are actually offering different things to their employees, like from their benefit standpoint, to where you're able to do these kind of resources. And they're getting very creative because they want to attract very competitive staff. And so for that reason, they're looking into making sure that they offer things like fertility resources and also coverage as well to their staff, really. You know, it's not just about gym memberships, but it's more so about being creative, understanding where people spend their time. So they're really getting into that fertility space. So you want to consider freezing your eggs. You want to make sure that you, like I stated on the presentation, that you're maintaining a healthy weight, that you're going and you're making sure that you're getting your biometric screening. What's your cholesterol like? What's your diabetes like? If you have diabetes, you want to make sure that you're doing the necessary things to prevent disease, so that when it's time to get pregnant, that you're actually the healthiest you can be. Also, if you know that, you know, it's some years to go, you want to consider egg, you know, fertility issues or fertility treatment. You also want to reach out to doctors and do a baseline consultation. The reproductive endocrinologist, which we refer to as REIs, you want to make sure that you actually just have a conversation with them. Like, you may not be there yet, but I'm actually going to get information. So I tell people, don't wait until something happens to go get information. You want to get that information beforehand. So just sit down and talk with the OBGYN, explore your options. Sit down and talk with a reproductive endocrinologist to explore your options. And also, we do things like telehealth. I do telehealth consultations all the time. Sometimes these people have doctors, but they may not necessarily be able to have that conversation with their doctor that they can have with me. So a lot of times I will have consultations with people who've seen a doctor for a number of years, but they don't feel like they can have intimate conversations with them. And so they call me up, and I'm just pretty much an extension, almost like what a doula or a midwife would do. I'm an extension of their OBGYN, and I'm giving them information because they can talk to me. And in your situation, you're in Carbondale, you may not necessarily have a ton of multicultural physicians. And so telehealth is something that is, you know, is booming. the state funds for telehealth for that reason, so that we really can expand our reach to patients like you. So those are some things that I would say. Make sure that you're maintaining you're in optimal health. The blood pressure is controlled, diabetes. Have conversations with your family members as well. Know your family history, know what you're up against, because we get these shocks in pregnancy, but had we talked with our mom, dad, things like that, we would know what conditions that we're actually going to be predisposed to, or what we might actually encounter when we become pregnant. So optimizing your health, know your family history, sit down and have preconception conversations with reproductive endocrinologists or OBGYNs as well, and explore telehealth.
Thank you so much, Dr. January. Sorry, Felicia.
There's not much more to add to that. I think a big part of it, though, is making sure that you are talking to your OBGYN or whoever is your women's health provider, and letting them know, just like you've shared that you want to with us, but that no, you're not currently in a relationship, but you want to be ready. And if they're not taking that conversation seriously, and if they're not offering you other resources, then that's a sign of a potential problem. And I would encourage you to seek your healthcare somewhere else. Because if it's important for you to bring it up to them, it should be important for them to help get you the answers that you're looking for. So that would be the only thing I have to add, in addition to what Dr. January already said. Control, that's it. Control what you can control, and you now know, so get in the best shape and be the best you can be, because a healthy baby outcome happens long before the egg and sperm meet.
Mm-hmm. Thank you so much, Sora Felicia. I see we got a couple other hands raised, so what I'm gonna start to do is just call on somebody. Me and Marquia will just call on a attendee, and then just ask one of the Soras to answer that question. So Sora Marquia, I was gonna say Latana, I believe, has had her hand raised, so you can pick that Sora that's gonna answer that question.
So for Latana, you can go ahead and answer or ask your question, and then we'll go to Sora Crystal for the response.
Okay, thank you. I also enjoyed this. I did learn a lot of vital information. But my question is, I'm also older and due to career and waiting to marriage to have a child. I at least want to have one. But my question is, do you recommend anyone that is of high risk or up in age to seek care from a fetal medicine doctor on top of an OB, or is it on a case-by-case basis?
I'm going to say that I would think that the OBGYN would make the recommendation once they are seen by the primary care doctor with that case.
That is the case. So essentially what you would do is you would have your first visit with an OBGYN, and then we would essentially send you for a referral to a maternal fetal medicine doctor, and then we would co-manage your care.
Oh, thank you.
Thank you. So Sora Faith, I see that you have a question, and we'll throw that over to Sora Monica.
So this is really not a question, but as an oral health care provider, I just want to introduce the importance of good oral health care during pregnancy for both the mother and the child. And so I'm just going to drop a link. I mean, I can get into all kinds of other things about what periodontal diseases do to and its role in preterm low birth weight babies. I could get into all of that, but I'll just make it simple and then just drop something from the March of Dimes in here about oral health care. And that's my comment.
I'm going to touch on that as well, because many people, she's right, many people do not know the importance of good dentition during pregnancy. Poor dentition has been known to cause preterm deliveries as well. And what you want to do is that when you do go in to see a dentist, if you're pregnant, you want to make sure that you get just a note from your doctor, your OBGYN, letting the dentist know that it is okay to actually care for you, because many people, unfortunately, whether you're pregnant or not, many people will say, oh, she's a woman, I can't do anything for her. And specifically, if you're pregnant, they're going to say that they can't do anything for you, but they can. Most times when people have, whether it's a dental infection, you can take most antibiotics. There are certain antibiotics, obviously, that you cannot take, but for the most part, there's a slew of antibiotics that you can take. Pain medicine as well, is totally fine to take. We don't recommend Motrin or anything that's an NSAID, but however, Tylenol, Percocet, in minimal Percocet or hydrocodone, we will prescribe that or have dentists prescribe that as well if you were to get a tooth pulled. But it's very important. Dental care is very important in pregnancy because it really has been shown to increase risk of preterm delivery.
Thank you. I've never heard that before. That's brand new. So thank you, Soros, for sharing that information. Jillian, we'll go ahead and take your question and we'll throw it over to Dari for the answer.
Good evening. Wonderful presentation. Everything has been very, very helpful and informative. My question is, I'm older as well. I had my first child at 40. He's 3 years old now, and we've been trying to have another child since then, and we've gone through infertility issues and started working with the doctor and whatnot. And I'm now at a point where I'm just trying to figure out whether we want to keep going or not. I'm getting ready to turn 44. So my question is, I've never worked with a midwife or a doula, but is that something that they would help have those conversations? A lot of times I always felt like I was just another patient, rushed through questions, didn't get a lot of information, or, I just felt like just another person coming in and out of the door a lot of times at the different appointments. So is that something that a doula or a midwife could help have those conversations with the doctor, or is that not something that they do?
I think, yes, I would say yes to that, especially for the doula. Like Kyla said, doulas are definitely like another partner for you. They definitely do a lot of advocating for the patient, and they can give you a different perspective on, what you feel like is going on and what message you're trying to send to the physician, and just make sure that, what you're wanting and, what plan you're trying to set in place is, set with the entire team. So I do feel like doulas are very helpful in advocating for the patient and just kind of bridging that gap between the patient and the physician.
I wanted to comment on that because, and I apologize, I'm exhausted. I worked 24 hours, but I wanted to comment on that because this is a common thing where people don't necessarily feel comfortable having conversations with their physicians, and they also just feel like a number, and that bothers me. And so for that reason, I did a talk in Miami with a group of ladies, and what the message that I wanted to convey is that hold these people accountable. You have to go in prepared and hold them accountable. I understand that people are short-staffed, blah, 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 and all that, but this is your healthcare. So I want to make sure that you all are make sure you do the work, go in with your questions, have them, outline, make sure that they don't leave that room until your question is answered. Like I said, telehealth is an option if you feel as though they still didn't answer your question. Like I said, in my guide, I address these are the questions that you need to be asking so that you can make it concise. It doesn't feel like, you're wasting their time or you're taking too long. These are the questions that you need to be asking. These are the things that you should expect with this visit. These are the things that you expect with fertility, endometriosis, fibroids, bacterial vaginosis. Ask these questions, hold these people accountable. The young lady who asked about maternal fetal medicine doctor, many times I refer my patients to maternal fetal medicine doctors. And when they come back to me, they'll say, well, what did they say? And I look at them like, well, you were there at the visit. You tell me what they said, but they're more comfortable with me. So they think, okay, well, they sent the report to me. Hold these people accountable. Ask questions. This is your body, your health. So you got to make sure that you ask these questions and you are not treated like a number. And people, the one thing, we're in the unfortunately, in the culture of cancel culture, so people don't want a bad review. They don't. But it's okay to go to another doctor, get a second opinion. I even tell people, like, I give them my recommendations, and I tell them, before you make a decision, why don't you, go get another recommendation, come back with your help, come back with questions, come back with family members or what have you, because I want to make sure that I'm providing the best care possible, but hold these people accountable, come with questions, do your research. Many times patients come to me and say, hey, Dr. January, I researched this. I heard about this new medication. Have you heard about it? And I say, no, but I look it up. And then, it's a group effort. So make sure you hold these people accountable, go in with questions, do your research, let them know that you know a little something about a little something.
That is so important to advocate for yourself. So thank you, Dr. January. Are there any further questions from our audience?
This is Stephanie. Can you hear me?
Yes, go right ahead.
Thank you, ladies, for this presentation. And thank you, Dr. Eboni and my other stars for the presentation. You just mentioned something that I was very curious about. And during my first pregnancy, actually, it was a big issue for me. Fibroids. What impact does fibroids have on just the impact of having healthy children or being able to have children at all? And in my particular instance, I just had like a really severe attack, very severe attack one night, but thank God it just subsided as quickly as it came. But when I went to see the doctor, basically what he was saying was, well, it's the fibroids or the baby, you choose. Like what? But luckily it just subsided. But what, because Black women, I think, are more susceptible to having fibroids, but if you could answer that.
That's also a great question, and a question that I get often and I address in the guide, which is that fibroids, unfortunately, many women don't necessarily know that they have fibroids until they go in for an ultrasound during their pregnancy. Many times when this happens, they're not very big. Some are small, some are moderate size. And some, one of the things that fibroids can do is that they can stay the same, they can get bigger, or they can get smaller during pregnancy. Many times they don't stop women from getting pregnant. Depending on the location, if it's blocking one of the tubes or both of the tubes, then it may be a little bit more difficult to obtain pregnancy. But oftentimes, many people with fibroids get pregnant just fine. Now, one of the issues that you may have when you do get pregnant, depending on the size, if it's a nice size fibroid, and let's say the gestational sac is implanted on the fibroid or near the fibroid, then you may potentially experience either miscarriage or preterm contractions, not even necessarily preterm labor or actually preterm delivery, but some people will experience preterm contractions with fibroids. So sometimes it's degenerating or it's becoming necrotic sometimes. Then people will experience pain during pregnancy. However, it all depends on the size and also the location. Like I said, many women will find out that they have fibroids during pregnancy. They go on to have nice normal deliveries, but sometimes people will have preterm contractions that, are managed just fine. Other times you have fibroids that can get in the way, implantation issues, which can lead to miscarriage or preterm delivery, but that's in rare instances. So when that happens, let's say you go in for one of your well woman's exams and you just so happen to come in with complaints of excessive bleeding during your menses, then we may potentially do an ultrasound. And an ultrasound, we find a big fibroid that's pretty much encompassing most of the uterine cavity. If that is the case and you want to achieve pregnancy, then we may offer you something called a myomectomy, which is where we essentially chew up the fibroid if it's pushing on the lining of the uterus. Sometimes you have some that don't just push on the lining of the uterus, but they push in the lining through the muscle and also towards the outside into the pelvis. So when that happens, sometimes we have to do an abdominal myomectomy where we actually open you up, open your uterus up essentially, but we make an incision where the fibroid is and carve it out, kind of like peeling it like an orange. So when we do that, we have to close the uterus back up in layers. And unfortunately, a person who had that particular procedure has to have a C-section because we don't necessarily want you to contract and essentially the baby is going to go to the weakest area, is going to be expelled the weakest area, and that will be through the abdominal cavity. So people have had abdominal myomectomies where we've had to carve out the fibroid and stitch you back up in layers. Then we just schedule a nice normal C-section. But oftentimes women have nice normal pregnancies with fibroids. If they're super large, pushing on the uterine cavity, sometimes we have to do a myomectomy. Sometimes it can cause miscarriage. Sometimes it can cause preterm contractions. So all is not lost if you have fibroids and want to achieve pregnancy. So we can either get rid of them if they're causing a problem, but if it's not broke, we don't fix them. But many times, many women are diagnosed with fibroids when they go for their first ultrasound.
Thank you.
Thank you, Dr. January. I do see that a question was asked in the chat in Kenya. If Felicia's response was good for you, just put a virtual thumbs up. But the question is, we talked about preventable concerns. How preventable are the concerns that are heart related? And we can, the answer was good for you? Okay. Perfect. And are there any?
Yes, ma'am. Thank you. I apologize. I got off mute a little bit late, but yes, that does make sense. I understand that.
Okay, perfect. Thank you. Are there any other questions?
I do have one. What would you recommend for folks? And I'm just gonna be transparent because I don't mind. So I'm severely anemic, and so I have to take birth control because my iron gets so low where I have to get iron infusions. What are some things you would recommend? You know, obviously I'm not trying right now at the moment, but in the future, like that is a concern that I do have because again, I have to get, you know, my iron gets so low that sometimes if it gets low enough, I have to get a blood transfusion. And so what are some things that you guys would recommend for those who, and I have reoccurring cysts as well. So what are some things you would recommend for those who kind of, you know, like you said, getting ready for it, but also when you kind of have some things that may affect or, you know, kind of have you to cause some issues along the way?
So go ahead, Dr. January. I was going to throw it to you, and then if anyone else has anything to add.
So many women will experience anemia in pregnancy, before pregnancy. So you want to make sure that prior to pregnancy that you're eating an iron-rich diet. So green leafy vegetables are key for sure. When you come in for your first prenatal visit, and let's say you're not pregnant, you come in for a well woman's visit. One of the lab things that I will check for is I'll do a CBC. So I'll check your hemoglobin level. I'll see where you start. If we need to put you on iron, then we'll definitely do that. Many times, if I know that you have an issue with anemia, then I'll put you on iron twice a day with the stool softener because we know that iron is going to constipate you. So we tank you up. And if you're one of those people who experience anemia and you come in for your first prenatal visit and you're anemic, then we monitor it. We monitor it on an ongoing basis so that we are prepared when you go into labor, because we know that you're going to experience some blood loss. So many times when we know that that is the case, then we have blood just ready for you. We have it ready, and we make sure sometimes we will transfuse you beforehand if it's significantly low, just anticipation for that. So the main thing is to make sure that you're taking your iron. Many people, I put them on iron, they don't take it because it constipates you. But what I also do is I hardly ever prescribe iron without a stool softener. I hardly ever prescribe anything without water. And that is, water is the number one fix to constipation. So oftentimes many people are getting constipation from the iron because they have poor water intake. So water. I usually prescribe the iron in combination with a stool softener as well. So you want to make sure that you stay on top of your iron pills, and you make sure that you stay on top of eating an iron-rich diet, green leafy vegetables. And you want to make sure that you're going in for your testing on a routine basis to check your hemoglobin level. So many times we'll do it what we call Q4. So every 4 weeks we'll check you for anemia, or we'll check your hemoglobin level.
Thank you.
Mm-hmm.
Sora Monica, you have a question?
Yes, I had a question. Thank you, everyone. And all of the information has been really great. But my question is more so, what happens when you're on the other side of being in your childbearing years? So I am on the other side of that. I'm not going to have any more children. I've kind of passed with the perimenopausal. So now I'm having menopause symptoms, hot flashes, tiredness, brain fog, sleeplessness. So prior to all of that, I was heavy with migraines, flooding, fibroids and all that. So the hysterectomy was recommended. And then immediately afterwards, it feels as if I woke up with all of these menopausal symptoms, but I'm not quite comfortable with just taking medication after medication. And I'm wondering, what is a simpler, more natural way of dealing with this flood pretty much of symptoms?
And we'll throw that to Sora Crystal, and then if anyone wants to add.
I'm so sorry I didn't get the last part of that question, Sora Monica.
So the question is, what do you do with the flood of symptoms that come with being on the other side of your childbearing years? What are some natural ways of dealing with being menopausal, with the hot flashes, with tiredness, with sleeplessness, and kind of being with the brain fog?
I'm gonna be honest, I don't know.
So Felicia, do you want to chime in as well?
Well, a lot of it would depend. Did you keep your ovaries?
Yes.
It's kind of a multifaceted question, because if you didn't keep your ovaries, then yeah, you woke up and you were thrust into menopause. But if you kept your ovaries, then even with the removal of the uterus, there should be some hormone production going on. What I would encourage you to do is, once again, go back to your women's healthcare provider. I would encourage you to ask to report what symptoms you're having, and then they can check your hormone levels. They can also send you to still reproductive endocrinology, even though it's just a specialized facet of endocrinology and they deal with hormones. So then they would be able to kind of talk to you more about what hormones you may be lacking, where you are, and some symptom relief that may not be necessarily thrusting you like, here's 5 pills today. I will say that menopause is a part of aging, and that it does come with some struggle for most women. For most women, there are some symptoms that are just not what we like. Because y'all know I'm pretty transparent, I am currently still in my perimenopausal phase. So I have about 1 cycle every 11 months. It's just lovely. But the symptoms for me have kind of died down a little bit in the last couple of years. I'm not having the night flashes. They have gotten better with time, is what I'm trying to say. Initially, they were not lovely. And I was like, no, I'm going to have to take some of those pills that I didn't want to take. But they have gotten better in the last, I would say, 12 months or so. So, but I do encourage you to go have some lab work done. And you do want to make sure that there's not something else going on as well, that it's not something else going on just coincidentally when you had your hysterectomy that should be addressed. So step 1 is going to be going in, getting a nice comprehensive exam and some labs so that you actually do know what's going on, and then moving from there.
Thank you so much. I'll take that advice.
No problem.
So thank you, Sora Felicia. I do have a question, and any one of you can just unmic and pick it up. So with us as Black women being 3 times more likely roughly to die during childbirth than white women, what is the best way for us to kind of advocate and make it known of these issues? It kind of seems like, I know it was mentioned that we're overlooked and kind of pushed to the side, but on a local level and even a national level, what can be done to advocate even more for African-American women?
When you talk to your provider, ask them if they're familiar with it, tell them what your fears are. Your provider should know what your fears are and what your concerns are. So when you sit down with the provider, don't get jaded by how nice the waiting room furniture is. When you get in the room with the provider, you need to say, I have some concerns. I'm concerned about dying. I'm concerned about my risk of dying. I'm concerned about my family history. And their response really tells you all you need to know. If they dismiss your concerns, if they're like, yeah, we don't even worry about that, you're just 6 weeks along, that's a problem. If they're not willing to sit down and say, okay, well, let's talk about those concerns. Let's talk about maybe what your comorbidities are right now. I can see that you're well versed on this. So let me meet you where you are and address your concerns. So it might be time to look elsewhere for a provider.
So with that, just I know like on a one-on-one with your provider, but like on a national scale, what can we do as African American women to advocate for other individuals who might be facing that? Like, is there currently any legislation that we should be trying to support? Like, where are those resources and how can we get involved, or is that available?
I mean, personally, big proponent of universal health care and child care in this nation. We really don't care about women and children. We like to say we do, but we really don't. On a national level, you're talking about outcomes, especially with people of lower socioeconomic status, people who don't have paid time off. I mean, I've had patients who went back to work 2 weeks after having a baby because they work in fast food and they don't have any sick time. And if they don't work, they don't get paid. Well, the issue comes with, number one, that's not good for your body. And number two, who's keeping a 2-week-old baby? Yeah. Baby cannot go to a licensed childcare facility. So then we're also putting children with unlicensed persons. We're putting children with people who may already be stressed out. We are increasing rates of child abuse and other things, which are also negative outcomes for Black and brown women and families. I think advocating for the family, I think pushing for legislation, I think also encouraging our Black and brown children that are bright to go into medicine. We have to have people at the table for the conversation. When we're not encouraging our young people, when we're not encouraging them to look at science careers, to look at healthcare careers, to look at even careers in law and legislation, healthcare administration, we have to have people at the table who look like us, who are advocating for us. So, I think there's not really any one place. There's so many different places where we could make an impact and make changes. I think we just got to pick one.
That's excellent. Thank you, Sora Felicia. We do have a question in the chat from Anna Rose. She says, I'm still in my childbearing years, but how do I avoid a hysterectomy, especially since it runs in my family? Also, are all fibroids and cysts non-cancerous?
So I guess I'll take it. Yeah. But I want to say that I just discovered how to see you all. I'm sorry, after all this time, I now can see everybody. So that's why I'm over here looking really weird, because I've had technology issues, but good to see everybody, finally. So fibroids and cysts, right? I want to make sure, I gave a talk on this as well, and I want you all to know that fibroids are different than cysts, because a lot of times people combine the two words and they say, I have fibroid cysts. And I'm like, no, you don't. Now, in the breast, there's something called fibrocystic breast. But in the uterus, there's fibroids, and then on the ovaries, you have cysts. Now, you can have some cysts on the cervix as well. We call Nabothean cysts that actually lubricate the vagina. But cysts are on the ovaries and fibroids are in the uterus. So just FYI, fibroids are benign. They don't have a potential to become cancer. There are some masses in the that actually they're from a particular, a similar cell line as fibroids that can go on to develop cancer, but not fibroids themselves. And in general, cysts are benign. There are some cysts that can become cancerous, but usually they're at the extremes of age. So you have something called dermoid cysts, and then you have cysts that are in really older women that don't necessarily bother any of us, but just in general, cysts are benign. And many times we get cysts every single month. Some get bigger, some get smaller. Many times they resolve on their own. If you have endometriosis, there are cysts that you can get with endometriosis called endometriomas, which are basically cysts that are full of just old, dark looking blood. But cysts in general do not develop into cancer. Benign, simple, what we call simple cysts. So these are cysts that just have fluid in them, but they do not develop into cancer in general. But there are certain cysts that can develop into cancer, but in rare instances. And these are just usually at the extremes of age. So young girls that, you know, have hereditary cysts, and then older women. So those shouldn't cause you any problems. As far as, there's very rare that even Black women get ovarian cancer. Now, when they do get ovarian cancer, then it's usually secondary to excess weight. So I tell people that there are two cancers that we cannot screen for, that but are unfortunately secondary to excess weight. That's uterine cancer and ovarian cancer. Cervical cancer we can screen for. That's called the Pap smear. Now, as far as hysterectomy goes, I have to ask a little bit more information about your question, but in general, people say that hysterectomies run in my family. Hysterectomies is the surgery. That's what fixes whatever the problem is. So you have to figure out what is the problem that runs in your family. So if you're referring to fibroids, fibroids run in Black women. They're not necessarily even hereditary. It's more so just African-American women are predisposed to fibroids. So it's not, so it's fibroids. So you have fibroids that run in your family, or just in general in women. So hang on, I'm pulling up the chat so I can see. Okay, that was a different question. But question about the fibroids. So do you have fibroids?
I believe she's saying she has fibroid. No, she does not have fibroids.
You do not have fibroids. How, if you don't mind me asking, how old are you? Or you can just say a range. You're
26.
Okay. Have you had an ultrasound ever? No, just Pap smear. Okay, so you don't know that you have fibroids. So if that is the case, I would go and get an ultrasound, or ask, you know, your provider. If you're having, for example, heavy periods or something like that, you can even just come up with a problem, and that would really push them to get an ultrasound to see if you have fibroids. So fibroids, what I tell people is that fibroids have the potential to grow until the age of menopause. Menopause is essentially when the ovaries stop working. The ovaries secrete estrogen. Estrogen is what thickens the lining of the uterus when we have cycles. And it also, estrogen is also what feeds fibroids. Excess fat also contains estrogen as well. This is why some people who are a little bit heavier, or when people gain weight, they'll say that my cycle became heavier. Well, that's essentially because of the estrogen in fat. But ovaries secrete estrogen. Estrogen feeds the uterus. Estrogen also feeds fibroids. So if you're not on birth control, you have the potential to develop, or if you have fibroids, you have the potential for them to get larger until you get to the age of menopause. So know that. So I know some people are so anti-birth control, but in actuality, it can actually prevent a lot of different things. It can prevent ovarian cancer, it can prevent uterine cancer, and it can also stop fibroids from getting bigger, because it essentially takes your normal estrogen level and it takes over it. So it essentially brings it down lower so that you don't have as much estrogen feeding fibroids. So that is one of the ways you can potentially prevent it. And also just a healthy diet. You know, make sure that you're not eating meats that are full of hormones. So you want to make sure that that is what you're doing, that you're eating more of a plant-based diet. That can also help as well.
Thank you. So we have another question in the chat. Are there any long-term health risks of severe diastasis recti? Does it affect future pregnancy or the ability to get pregnant? So looks like, is there any, yeah.
Let's see, I'm trying to find the chat so I can see the question.
And I can repost it.
It was at 8:26, Dr. January. It's from Jillian.
Oh, that's it. So essentially, for people who don't know, That's really just a separation in the muscles, your rectus muscles. So it's essentially here is if your muscles were really tight, especially if you work out, doing your abs, staying on top of your cardiovascular health, like we're supposed to, then let's say you have tight muscles. When your uterus grows, then obviously everything else grows. You have the potential for those muscles to separate. Some people, depending on your genetics, if you have great muscle fibers, then it retracts back after delivering, your uterus goes down. But some people, maybe they have, just from genetics, have weaker muscle fibers to where it just stays loose. So if that is the case, you'll see people who their abdomens poke out a little bit. Let's say they're a super slim girl, but for some reason you can see their belly button, or they have more of a protuberance in their abdomen. Then these are people that their rectus muscles aren't necessarily as tight. So they're not doing this, they're doing this. So these people have the potential to get hernias as well. Does it stop you from getting pregnant? Absolutely not. This is more superficial. So I'm a visual learner, so I have to tell you guys that. So if this folder is skin and this notebook is fat, obviously the fat layer and the skin layer varies in different people. Below that, you have something called the fascia, which is a thick layer that actually protects everything and keeps things inside the abdomen. And then below that, you have a very thin layer called the peritoneum. And then you have your bowel, your intestines, all of your organs. Down below, and then also in relationship to the fascia, you have the muscle. So in certain places, the fascia is above that. In certain places, it's below that. The uterus is an organ that's all the way in the pelvis. So it has nothing to do with the skin layers, with the muscle layers whatsoever. It has nothing to do with you achieving pregnancy. Pregnancy has to do with your hormones, your tubes, your uterus, and whoever has the swimmers.
Thank you. So our next two questions come from Taylor Smith Whitehead. She would like to know, is it proper to tell a patient during labor to lay flat on their back and to stay on their back to speed up the opening of the cervix, even though they were told that that the pain was unbearable multiple times? So I'm assuming they told the doctor the pain was unbearable, but the doctor requested that they stay laying on their back. And then the second part of her question is it safe to get an epidural when you're already fully dilated?
So somebody looked like they wanted to take that question. Or you want me to do it? Anybody? Okay. So that's interesting, an interesting question, because to lay on your flat to open up the cervix, are you sure about that? That they wanted to open the cervix, or
the
what? Pushing?
No, it wasn't. They said I wasn't fully dilated yet, so they said for me to lay flat on my back for that reason.
So just laying on your back has nothing to do with dilating the cervix up. So usually if someone tells you to lay flat, it may be during pushing to open up. So some doctors will tell you that, but it has nothing to do with cervical dilation, because laying on your back and the cervix, that's from an anatomical standpoint, it has nothing to do with the other. So that doesn't make sense at all. So that's why I'm kind of confused about the question as, was it during pushing, or because laying on your back has nothing to do with your cervix dilating up. That has more so to do with your contractions and the strength of your contractions. So usually, like, for example, if we were to induce someone and give you Pitocin or a pill called Cytotec, those things are to open up your cervix. Contractions actually open up the cervix, not position.
Yeah, that's what that was told to me. So
contractions open up the cervix. The position.
Mm-hmm. Well, I was having contractions as when they were telling me to lay flat on my back, and that was the reason they gave me.
Yeah, then I'm not sure of that. I would need a little bit more information, but that doesn't sound right. Contractions open up the cervix, not your position.
Okay. Thank you.
The second part of the question is it safe to get an epidural when you're fully dilated?
Well, it depends on how low the baby is. Sometimes, you know, if the baby's ready to come out, then there's just not enough time to get an epidural. But if you have a good anesthesiologist, they can get it in really quick. Babies, even though you're fully dilated, doesn't mean that baby's low in the pelvis. So if you have time, still a little bit of time before the baby gets low in the pelvis, the contractions haven't quite done their job yet, and the anesthesiologist is, you know, they're pretty quick, then it's safe. But if for some reason the baby's getting ready to come out, then we don't necessarily want to do that.
Thank you. And then Jillian, if you want to come off of mute, she said that she has a history of hernias also, and she was wondering if there's any correlation. I
think she answered it when I was just explaining that was why I answered, why I asked it, because of those two together. Yeah.
Thank you. Okay. Are there any other questions at this time?
Okay. We're gonna move on with the agenda then if you don't have any other questions. So I'm gonna stop sharing really quick so we can get a group photo. I know there are 2 pages, so I'm gonna ask my Sorafate, who is normally our pick guru, to take a couple pictures of the group so that we have them for our record. So Sorafate, you let us know when you're ready.
I'm ready.
Okay, on the count of 3. 1, 2, 3. All right, now hold it because I'm gonna go to the second page. We're gonna do it again. 1, 2, 3. Okay, awesome. Thank you guys. We're not over just yet. We got a couple other slides and then we're gonna go ahead and let you guys get back to your evening. So I'm gonna turn it over to my vice president, who is Markia Haywood, who will discuss our upcoming events.
Okay, excuse me, you guys. I'm kind of fighting a cold. But thank you once again to all of our panelists. The information was amazing. I know I learned a lot. Thank you, Dr. January, for everything that you have shared on this evening. And I look forward to having you back. GKO, we have some upcoming events that we would love to see you all at. April is also Financial Literacy Month. So join us on next Wednesday for our Financially Lit Book Club. That starts at 6:08. You can head over to our website for that information. We also have on the April 23rd, a Stress Less Forum. That's something that you do not want to miss. It's going to be on Saturday, April the 23rd at 11:08 a.m. And you can register online at our website, or you can scan the QR code. And then on the 27th, we have our Financially Lit workshop. So come learn about budgeting, learn how to take care of your finances, secure that bag. This is a season to make that money and to save that money. And finally, we are celebrating our 81st anniversary and chartering date. So we want you to celebrate with us. We have the Masquerade Ball. It will be a virtual event. So go ahead, get those masks, your Mardi Gras masks. But it's something that you want to participate in, get dolled up from the comfort of your home. And you can register as well on our website. The information is in the chat. And before we get off, we would love for you to take a survey. Let us know what you thought about this event. If you have any follow-up questions or suggestions, that link is available. We love to hear from you so we can continue to provide content that you all would like to see and hear in the future going forward. So thank you for participating and coming out. We appreciate each and every one of you. And thank you again to my sorors for all the work that you put in for this event today.
Thank you so much, Sora Markia. I want to then echo that as well. I just really want to thank Dr. January, Sora Monique, Sora Crystal, Sora Darielle, Sora Felicia, Sora Crystal, really just for giving your insight, your resources, your knowledge and your wisdom in regards to this topic. I think it's something that obviously scares a lot of women. And I think you guys hit on several different topics for us to really, really think about, go and talk, have conversations with our family members to really, make them more aware and to advocate for ourselves. So I thank you all for joining us this evening and, sharing your experience, giving your wisdom and your pearls of wisdom. I also want to thank our attendees for coming tonight. We have a poster that we have on our website that's just really promoting Black Maternal Health Week, which did start on the 11th and goes through this week. It does have some statistics. We are going to be making donations to support the Black Mama Matters Alliance. They do allow you specifically to choose where you donate those funds to. So we really want to support them as they are doing a lot of work specifically in this field, educating and advocating for Black mothers around the Black maternal health issue that is at hand. So again, you can scan the QR code to donate. You can go to their website, and they also have a lot of resources that you can utilize as well. But again, I want to thank my sorors. I want to thank all of the guests for attending this evening. Hopefully you were able to gain a wealth of knowledge. Feel free to also, I encourage everybody to take the survey that my soror Markia did drop in the chat box, as it will allow us to have more, feedback about how these forums are perceived by the community. So without any further ado, like I said, thank you everybody. I hope everyone has a great evening. Go out, educate, advocate, and make your family aware of these issues, and make sure that you are making a difference where you can for those that look like you. Have a great night, everybody.